In this lecture, we're going to talk about the basic function of the heart, the structure of the conduction system of the heart, and then the chambers. The next lecture, we're going to talk about the valves and some other associated clinical pearls. All right, so start out with an overview of the heart. So the basic anatomy, it's a 4-chamber heart responsible for pumping blood to every organ and tissue in the body. So you have your right atrium here, right ventricle here, left ventricle here, left atrium here. So 4 chambers, 2 atrium, atria is plural, and then you have the 2 ventricles. The atrium is more responsible for receiving blood, either from the body or from the lungs in the case of the left, and then it serves as a conduit for blood to move into the ventricles, and the ventricles are the main muscular pumping chambers of the heart. So on the right side, you also think of the heart as the right side of the heart and the left side of the heart, or the right heart and the left heart. So on the right side, it receives deoxygenated blood coming from the body. So, metabolic metabolism uses up oxygen, generates CO2, so you have deoxygenated, high CO2 content blood. Coming in, it's received by the right atrium here. Then it goes into the right ventricle, and then it's pumped out into the pulmonary trunk and pulmonary artery to the lungs. Goes to the lungs, and then it comes back around from the lungs into the left atrium, so now it's oxygenated blood. It dumped off CO2 in the lungs, breathe that off, it takes in oxygen from the lungs, comes back to the left side, and then it comes to the heart, or the left side of the heart, then the left ventricle, goes out through the aorta, and then off into all the systemic arteries to complete the systemic circulation. So I said a lot of this in the previous slide. We'll start here. So that after receiving the blood from their respective sources, the atria serve to empty the blood into the primary pumping chambers, which are the ventricles. Main driving factor of blood from the atrium into the ventricle is actually the pressure gradient. So the pressure at this point is higher in the atrium than it is in the ventricle, and so that's what drives it. And then what's a secondary force pushing blood in is that the atria actually themselves will contract as well. So they'll contract as well to push blood in. Now, one thing to note is that the atrioventricle valves, so that's this valve and this valve, so this would be the tricuspid valve, the mitral valve on the left side. These are what separate the atria from the ventricles. Then you have the semilunar valves, because they have these kind of semilunar cusps is how you could describe it, like this. And this is the pulmonic valve, and then you have the aortic valve, which is tucked back in here, which guards the aorta. And these are what regulate blood flow from the ventricles into the great vessels. So very basic histology. We're not going to go much past this. There's 3 major histological layers. They're analogous to the 3 layers of the blood vessels. So you have the endocardium, which is similar to the tunica intima. So you have the endocardium here, and this is the main layer here. Then you have the myocardium, which is this layer right here. That's analogous to the tunica media. Then you have the epicardium, which is out here, the most outer layer, and that is what's analogous to the tunica adventitia. Then you have the pericardial cavity, and then you have that parietal layer. The visceral layer of pericardium actually is continuous with the epicardium. Then you have the pericardial space. Then you have the parietal layer of the serous pericardium, and then you have the fibrous pericardium, which is attached to the parietal layer. So just to talk about these in more depth, so the endocardium is the inner layer. This is where the blood is contained in the chambers. So this is what lines the blood, similar to the tunica intima, containing endothelium in the blood vessel. And so it lines the chambers of the heart. The myocardium, this is the main driver, this is the muscular layer. It's what drives, the whole function of the heart. So this is where the cardiac muscle cells are contained. And again, it's responsible for the heart's pumping action. Then you have the epicardium, which is out here, like we talked about, the outermost layer of the heart wall, and it consists of connective tissue, and this is where the coronary arteries are actually running. So the coronary arteries, the main named coronary arteries, they actually run in this epicardial layer. Then they have branches that go down through the layer of the myocardium all the way down to the endocardium. And like we said, the epicardium is continuous with the visceral layer of the serous pericardium. We'll just talk a little bit about the cardiac cycle. So the ventricular filling phase, this is you could start at any one of these because this is continuously going in any individual for their entire life. So what happens is you have the blood come in. You can see that here. Like we talked about, on the right side, it comes from the SVC and the IVC. And it comes into the right atrium. Then on the left side, it comes from the lungs. comes into the left atrium here. And so what we have here is the ventricular filling phase. So as you can see by the arrows, the blood is filling from the atria into the ventricles. And again, the main driver of that is that the pressure in the atria is greater than the pressure in the ventricles. A secondary thing is that the atria can contract and they push blood along as well. And that helps kind of finish the filling off, if you could think of it like that. So then we move down to here. So you have the isovolumetric contraction phase. Now the thing here is that all four valves are closed here. In this part, the pulmonic valve and the aortic valve are closed, but these valves are open for business. So tricuspid valve, mitral valve, these are open, and that's what's regulating the blood flow into the ventricles. So in this one, the chamber, you could think of the chamber as a closed, it's an entirely closed area. So there's no opening, there's no escaping for pressure. That's why they call it isovolumetric contraction, because the volume does not change at all here. Okay, so the volume does not change. So what does change is you increase the pressure. So as you increase the pressure and increase the pressure, there's nowhere for the pressure to go because the volume isn't changing. So that's what happens here is during this phase is when the myocardium is contracting in the ventricles and significantly increasing the pressure in these ventricles to get it ready for the ejection phase, which is the next phase. So we get to here. So what happens here is that the pressure in the ventricles has to get to a point where it's higher than the pressure in the aorta on the left side. And then on the right side, it has to get to a point where, so that would be LV, and then we have RV. So the pressure in the RV has to get bigger than the pressure in the pulmonary artery. Okay, so when the pressure in the right ventricle here, when the pressure in here is higher than in the pulmonary artery, the pulmonic valve will open. That's what helps push the valve open, is this pressure difference. There's nothing else. There's nothing pulling it open or any kind of structural thing. It's strictly a pressure system. That's for all the valves. So at this point in contraction, they've generated enough pressure that it's greater than the pressure in the pulmonary artery, and you push blood out into the pulmonary arteries. Same thing here on the left side. The pressure here in the left ventricle has gotten great enough that it is greater than the pressure in the aorta. So it is able to open the aortic valve just like how the pulmonic valve opens. The aortic valve opens, and then the blood flows into the aorta and into the systemic circulation. And then once that is closed, once this phase is over, the valves close, and then the filling begins, and it's just one continuous cycle over and over again. This is another thing. It's not necessarily strictly for anatomy, but you hear these terms thrown around a lot. It's good to know what they exactly mean. It can help you understand some of the anatomy function better. So there's systolic blood pressure and diastolic blood pressure, and you often hear of 120/80 is the the normal blood pressure. The top number, whatever it is the systolic blood pressure. The bottom number is the diastolic blood pressure. So let's define what each of these are. The systolic blood pressure is the highest pressure achieved in the circulation during the contraction phase of the heart. So that a ventricular contraction ejection phase, that is what generates the systolic. So when the aortic valve is open here and there's blood flowing through, if the systolic blood pressure is 120, then during this ejection phase into the aorta, the pressure in the aorta and really everywhere is 120 millimeters of mercury. Okay. Then what happens here is you have where those valves close off, right? So then there's no blood flow going through here. Now, if you remember, the aorta and a lot of these other systemic arteries, they expand during systole. So because their walls, they're full of elastic tissue. Okay, so they have these elastic tissue, these aorta and these other large systemic arteries. So they actually expand out. So they're able to expand out just like how you stretch an elastic rubber band. So they stretch out during systole. So they move out this way, and they are able to accommodate more blood. Now what happens is when there's no more systolic pressure, when the aortic valve closes, then we're in diastole. These large vessels recoil, as we say here. So they recoil back. And by recoiling back, you're contracting down on the lumen here, increasing the pressure, and then that gives you almost like a second jet of blood. So this recoil of these vessels, that's what generates this diastolic blood pressure. And so that's what gives you your 80. So just a few basic terms. We're not going to get too into this. Again, this is not a physiology book, but just so you understand. So cardiac output, because you'll hear me talk about these, especially in the clinical pearls section. It's a physiological concept, and it defines the amount of blood that's being pumped by a heart over a period of time. It's usually liters per minute. So the average person is 6 liters per minute. So what does that mean? Normal cardiac function is that it's pumping 6 liters of blood per minute. If you may have heard of, someone's in heart failure, that's where they have decreased cardiac outputs. They could be, doing 2 liters per minute or something like that. Cardiac output, this is defined as heart rate multiplied by the stroke volume. So that's, this equation here, heart rate times stroke volume. So what is the stroke volume? The stroke volume is the amount of blood ejected by the ventricle, left or right. So you can define this as either on the left side or the right side during one contraction phase. So what's important to understand is, so if this is the ventricle, the left ventricle, could be the RV as well. So we'll do this like this. We'll have the valves in like this. The atria is up here. So this would be the left atrium up here. So blood comes in. So you have this amount of blood here. And you have the aorta coming out like this. All of this blood, so let's say this is all blood here. Not all of this blood it's a common misconception, is not all of the ventricle doesn't entirely empty. So not all of this blood is going to get emptied out. It's going to be maybe down to here. So the ventricle contracts, and then it empties out down to here. So it doesn't totally empty. So it's really whatever blood is left over. So the stroke volume is really calculated in a way where you take the volume that's left at the end of systole. So that's this volume right here, okay? Because you've ejected the blood. So this is the ventricle full. You eject the blood, then you're down to here, okay? It's just like any other container with fluid in it. So you've ejected out this much blood. Now it's down to here. So this is the end systolic volume, which is, ESV. So ESV, and then you subtract that from the end diastolic volume, because diastole is also considered the filling phase. So by the end of diastole, the ventricles are as full as they're going to be before you do the ejection. So this would be the end diastolic volume, this where the ventricles are more full. So you subtract what's left, the ESV, from this end diastolic volume. That gives you your stroke volume. Then you just measure the heart rate, multiply those two together, and you get your cardiac output. So really just a brief outline, this figures in your book, of the circulatory system. So you have the heart here, the lungs here. You have dual circulation is the way to think about it. So you have dual circulations. Okay, so what does that mean? It means you have two circulations acting simultaneously. So you have the pulmonary circulation and the systemic. So the systemic here, you have the left ventricle, which pumps blood into the aorta and all the rest of the systemic arteries, and it goes all through the body. And then at each organ level and each tissue level, you have these, at the tissues or the organ level, you have all this where you have O2 gets dumped off, other nutrients get taken away, and then you have CO2, which gets loaded into or picked up by the systemic capillaries. Then the CO2, rich blood and O2 depleted blood goes into the systemic veins. The systemic veins come back in. Then they enter into the right atrium here, and then they go into the right ventricle here, and that's where then you begin the pulmonary circulation. So the pulmonary circulation goes through the pulmonary arteries, which, as we've described, is the lowest oxygen content blood in the whole body, because this is towards the tail end of the circulation. So the blood comes in, it comes into the pulmonary capillaries, where it unloads the CO2, and then you have O2, remember, that's coming in from the atmosphere, and then it eventually diffuses into pulmonary capillaries, and then you have the pulmonary veins, which take this O2-rich blood back to the heart, where it can then get pumped out back to the systemic circulation. Notice the systemic circulation is the entire body versus the pulmonary is just the lungs. So the pressure, the way you can think of it is the pressure in the systemic circulation is high. So it's a high pressure system, okay? And then it's a high pressure system because you got to get which makes sense. You've got to get blood to every area of the body other than the lungs, versus the lungs is a low pressure, or the pulmonary circulation is a low pressure system. All right, so now I'm going to go through the conduction system of the heart. This is going to be a very basic overview, just the structures that are involved, how they're connected, and how that generates the rhythm of the heart. So the components, they carry electrical impulses throughout the heart to stimulate muscular contraction. So this is the system here, and we'll go through each of these in the subsequent slides. But really what they're composed of is specialized cardiac cells. So these aren't muscle cells. These are a special type of cardiac cells that actually spontaneously generate electrical impulses without any input from the nervous system. So these cardiac cells, the conduction cells, they act totally on their own. They don't need to have stimulation from the nervous system or anything like that. They generate the heartbeat completely on their own. What's regulated by the autonomic nervous system is the heart rate and the contractility, which we had talked about in the ANS lecture for the thorax, where the sympathetic nervous system increases your heart rate and your contractility, and then the parasympathetic nervous system does the opposite, decreases your heart rate, decreases contractility. So where it all begins, the SA node or sinoatrial node, you can see that right here. It's this kind of ball of cardiac cells up here, specialized cardiac cells, and they're in the wall of the right atrium, and they're near the opening of the SVC at the upper end of the crystal terminalis, which is kind of this smooth structure that kind of runs in this area here. And be aware of where this is, especially if you're doing a cadaver-based course. Make sure you won't see this, obviously, because it's a microscopic structure, but at least know on a cadaver heart where this is located. A lot of times professors will like to kind of tag. They'll put a pin through here or a couple pins and say what electrical structure is here, what conduction structure is here. The SA node is considered the pacemaker of the heart because it is the first area in the conduction system. And so it produces electrical impulses that travel throughout the entire conduction system of the heart. So they start here and then they travel all through the atria, converge on the AV node, and then down into the ventricles. The heart rate is altered the SA node generates these impulses at just a basal rate. It's for the SA node. The SA node is not responsible for adjusting the rate at which these impulses are traveled. That is actually changed by the autonomic nervous system. And so again, the sympathetic nervous system will increase the heart rate, so that when the sympathetic nervous system stimulates increased heart rate, it stimulates the SA node to shoot off more impulses. And then the parasympathetic nervous system sends input to the SA node via the parasympathetic, specifically through the vagus nerve, sends impulses to the SA node. And in fact, remember we talked about in the autonomic nervous system lecture that the vagus nerve is actually responsible for depressing the natural resting autonomicity of the SA node. So the SA node, if you were to cut the vagus nerve, the SA node would generate a much higher resting heartbeat than what's normal. And so what the vagus nerve does is it depresses the natural automaticity of the SA node, and so that's what gives you your normal resting heart rate. So 60 to 90 beats is considered the normal range. The vagus nerve is actually responsible for that. So the impulses from the SA node, they travel via the atrial conduction fibers, and you can see that they travel out this way through the walls of the atria, kind of out and around like this, and they travel around, and those impulses are just responsible for carrying conduction impulses to the atrial muscles and making sure that they are stimulated and they contract and help with ventricular filling. Now, these fibers are actually, you may have heard of a condition called atrial fibrillation, or AFib for short. So what atrial fibrillation is a completely uncoordinated contraction of the atria. They're just spazzing out. It's almost like a muscle spasm of the atria, and it creates an abnormal heart rhythm, and it causes inefficient pumping of the atrium. All these impulses will converge onto the AV node, which is labeled here for you. So it's this kind of bundle, this other bundle of specialized cardiac cells. And the AV node, as we'll talk about in a second, is almost like the gatekeeper. So all these impulses, they travel around the atria, and then they make their way back to the AV node. So the AV node itself, atrioventricular node, is named appropriately because it's between the atria and the ventricles. It's located at the interatrial septum near the opening of the coronary sinus. So the coronary sinus, it's the major vein that drains the coronary circulation, the circulation that supplies the heart itself. And then it empties air into the right atrium. So right near this opening, microscopically, is where the AV node is. And like I said, it acts as a gatekeeper for impulses traveling from the atria to the ventricles. And what it does is, the way it acts like a gatekeeper is that, so you have all these impulses coming, through the atria. They're shot off by the SA node. They're going through. They make their way to the AV node. And so the way it acts as a gatekeeper is it delays atrial impulses. So again, these impulses are traveling through here, and then they're all converging on this AV node. And we get to the AV node, instead of just going on to the ventricle, they're slowed down or delayed. And what that does is allows time for the atria to fully eject their blood into the ventricles before the ventricles contract. And so what that allows for is proper filling. So it allows time for the atria to properly fill the ventricles, so that the ventricles have the maximum amount of blood in them necessary, and then the ventricles are allowed to contract. So you delay this signal, and then it moves on and stimulates the ventricles to contract after they've filled. It also has pacemaker ability. It's slower than the SA node. So say for some reason the SA node was to become damaged, or there's blood vessels that actually feed the SA node, and if they were to become blocked off, and so you'd have develop ischemia in this region. For whatever reason, if the SA node becomes compromised, the AV node can actually act as a pacemaker, but it's a much slower rate than the SA node. And the idea of this is just to maintain the pumping action of the ventricles, so that to essentially keep the individual alive. This is kind of a survival mechanism. If you were to lose that SA node, you can still be kept alive theoretically by this AV node. So then you have the AV bundle, which is shown here, atrioventricular bundle. It's also called the bundle of His. You may hear of it referred to as that. And this is a bundle that extends out from the AV node, and it travels in the interventricular septum here. And it splits actually into the right and left bundle branches, and you can see that labeled here. So here's the right bundle branch, the left bundle branch, and you can see it wraps around here, wraps around here. What it essentially does is it takes these electrical impulses that have converged on the AV node, and it carries them all throughout the walls of the ventricle. So as you can see, they're long bundles here, both sides, and carrying these impulses all throughout the ventricular wall to ensure efficient contraction of the myocardium in the ventricles. So branching off of these bundle branches here, you have what's called the Purkinje fibers, and these are specialized conduction fibers. Like I said, they branch off both bundle branches, and you can see them here. They come off the bundle branches and they travel all through the wall of the myocardium. So they extend deep into the tissue. So if this was kind of a super fit, if this was the epicardium up here, and then the endo down here, endocardium, and then you have the myo in here. So if you have the bundle branch kind of traveling through here, the Purkinje fibers are going to take the impulse deep into the tissue. All right, so now we're going to go through each of the 4 chambers of the heart and point out their important anatomical features. First, we'll start with the right atrium, as shown here. Again, receives the oxygenated blood from the systemic circulation through the SVC and the IVC up here. And then also via the coronary sinus, it receives the coronary circulation, the blood draining from the system that actually supplies the heart. The atria, the 2 chambers, are separated by the interatrial septum. It's not a great picture of it here. It's behind these vessels, but it's a muscular wall between the 2 chambers. During development, the atria actually communicate with each other. So if we draw a nice box diagram like this, and we have our right atrium here, and our left atrium here, and we kind of have the openings like this. We won't go through all the embryology, but we'll give you enough so you have the idea. So then what you have here is an opening for blood to bypass and go from the right atrium into the left atrium. Since the function of the right side of the heart is to pump the blood to the lungs, what you're doing is bypassing the lungs and just sending the blood over to the left atrium, and then for the left side of the heart to pump it out to the circulation. And the reason why you can do this in utero is that the lungs aren't responsible for bringing oxygen to the baby. What's responsible for bringing oxygen to the baby is the umbilical circulations. The mother's oxygenated blood that actually comes in here and comes up through the IVC, and then it comes up into the right atrium. So it's already oxygenated. It doesn't need to go to the lungs. And so it bypasses the lungs and goes into the left atrium and then is pumped out. So that's why this system is in place. And so you have this what's called a foramen ovale, which is this kind of this opening here in the septum. And then you have the valve here, which kind of regulates blood flow. Again, just like any other valve, regulation of pressure. It's really to prevent retrograde flow of blood from the left atrium back into the right atrium. And what happens is the baby's born at birth is all of a sudden then the pressure in the left atrium becomes much higher, and then the lungs open up and they're able to pump blood out to the lungs. So it's really, again, it's the path of least resistance. So you have increased pressure here in the left atrium, decreased pressure in the lungs at birth, and so path of least resistance, the right side is going to pump the blood to the lungs instead of moving here into the left atrium. And then what happens is the valve seals over and seals this shut, and then you just have a remnant here. So what you have here in the adult heart, and if you cut open in a cadaver lab, if you cut open the heart, you'll actually see this. You have the fossa ovalis, which is this marked right here. So it's almost like a little thumbprint or fingerprint. And so that's an imprint of a remnant of the foramen ovale inside the wall of the right atrium. So this is the right atrium cutaway here. And then the other main thing to talk about is the right atrial appendage, or the right auricle, which is right here. And it's just kind of a muscular pouch extension of the right atrium. So there's nothing real significant. It's just another, kind of increased volume or increased expansion of it. The right ventricle comprises the anterior surface of the heart. So the heart is actually rotated. So this is, an anterior view. And so the most anterior chamber is actually the right ventricle. And that's what this chamber is here. As you can see, this is the right ventricle. Here's the left over here, and the left wraps around this way. And then the undersurface sits on the diaphragm. Remember, that diaphragm is that dome-shaped muscle on the bottom. So you have the diaphragmatic surface down here, which is part of the heart, which covers the diaphragm. You have the anterior surface, which is mostly the right ventricle, and then you have the posterior surface as well. Then what you'll notice, again, in the cadaver lab, if you cut this open, is the inner surface of the chamber is actually composed of these kind of muscular columns called trabeculae carnae. And you can kind of see these here. You'll know it when you see it, when you cut it open in the lab. But you can see it's these nice columns of muscle in the heart. And then also within the right ventricle are 3 papillary muscles that act on the tricuspid valve. So the tricuspid valve is a 3-leaflet valve. It has each of these as a leaflet. It regulates flow from the right atrium into the right ventricle. We'll talk much more about all the valves in the next lecture. The entire next lecture is devoted to valves. So, but just to give you an idea, the papillary muscles, there are these guys right here, and there's these kind of like conical shaped muscles, and they act to actually. So when you have in your ventricle here, and you have your valve in like this, and then you have these what's called these chordae tendineae, and we'll talk about these in more in depth, and they come down, and they're like just these kind of connective tissue cords that connect the valves to the papillary muscles. And then lastly, the last structure to make a note of is the conus arteriosus. It's a conical shaped, smooth muscle surface that helps, and it's located here on the surface of the ventricle, and it helps blood flow out of the ventricle and into the pulmonary trunk. So a specialized structure to be aware of in the right ventricle is the septomarginal trabeculae, and you can actually see that right here. It's very nicely shown right here. It's also known as the moderator band. So what it is a single band of trabeculae carnae, which is those columns of muscle, and it extends out from the interventricular septum, and it goes into the anterior papillary muscle. So in the right ventricle, there's 3 papillary muscles on average, 1 for each of the 3 leaflets of the tricuspid valve. And so what it does is, as you can see here, these red lines in this diagram, they represent the right and left bundle branches that we talked about in the conduction system section. So what the septomarginal trabeculae functions to do is it carries the right bundle branch. So here's the right bundle branch. It carries the right bundle branch of the AV bundle to the anterior papillary muscle. So it helps carry electrical input directly to this papillary muscle. And what this band functions to do is that it helps facilitate the conduction time and allows coordinated contraction of all 3 of the papillary muscles in the right ventricle. So it brings this direct line of the conduction system to this anterior papillary muscle. And by doing so, it helps bring this direct line of the conduction system to this anterior papillary muscle so that all these muscles can contract in a coordinated fashion. Left atrium, not much here to know about other than the main thing is it's receiving freshly oxygenated blood from the pulmonary veins. So you can see 2 of the pulmonary veins here coming from the lungs, and they come here and empty. The ones coming from the right lung over here are traveling behind the heart or posterior to the heart, so you don't see them here. These would be coming from the left lung. Just briefly, the main structure here is in the left atrium is the remnant of the valve of the foramen ovale. So you remember when we talked about in the right atrium, so you have your atria like this, the foramen ovale right here, which is that opening during utero, which allows blood to bypass from the right atrium into the left atrium, and then you have that valve that regulates it, and then this ends up, during birth, this seals up. So there's a remnant of that valve, and as you can see here, here's the remnant of the valve here. It's this kind of, again, kind of thumbprint shaped structure, raised structure here in the surface of the left atrium on the interatrial septum. The most clinically significant thing about the left atrium, and this is very high yield for board exam questions actually, is that it lies anterior to the esophagus. So let's see right here, in this cross section here. So here you have the esophagus right here, okay, and you can see the muscular layer here. And what you have here is the left atrium right here lying just anterior to it. So what's important about that is if the left atrium, which can happen in, say, rheumatic fever, where you have mitral valve stenosis, which we'll talk about more so in the valve lecture next, is if, say, you have some kind of process that causes volume overload, either heart failure, a stenotic valve, some process that causes volume overload in the left atrium. The left atrium can expand out like this, and press on the esophagus, and that would cause dysphagia or difficulty swallowing. So this is something that's an anatomical relationship that's commonly tested on board exams, and it's also good for your anatomy exams as well. Another important thing clinically is the left atrial appendage, which, just like the right atrial appendage, it's a muscular pouch extension of the left atrium. You can see it here. It's also called the left auricle, and there's pouch that extends out. It's important in the left atrium because this is a common site of clot formation in patients with atrial fibrillation. So if you remember, you have that SA node, and it's sending out signals throughout the atria like this. What happens here is in the atria you can have erratic signaling or almost like a muscle spasm in patients with atrial fibrillation. So what happens here in patients with atrial fibrillation, so if this is your left atrium, and you have kind of your appendage out like this, so this would be your left atrial appendage, is you can have inefficient flow out of here. So by having inefficient flow or static flow, stationary flow, what that increases the chances of is clot formation. When blood flow is flowing continuously, it's less of a risk of clot formation. When it sits around, the clotting cascade can get triggered and start forming clots. And so what happens is often, because this is kind of an enclosed little pouch here, is in the left atrial appendage you can have a clot that ends up forming here in the left atrial appendage. In fact, when they do echocardiograms looking for clots, the left atrial appendage is always a site that the cardiologist will look at for checking for if a patient has a clot. These clots are why these patients with AFib get put on anticoagulation therapy such as warfarin. And the reason for that is that this clot, say you have a clot here, it can get shot into the left ventricle, shot into the aorta, and then go out into the systemic circulation and cause clots out in the systemic circulation, specifically strokes. So this can put patients at risk for strokes. So that's why they're put on these anticoagulation therapy. The left ventricle is it's the major pumping chamber of the heart. So it's this guy right here. The inner surface, like the right ventricle, is lined with trabecular carne. It contains two papillary muscles, and you can see that right here and here. And because they act on the mitral valve, which, as you can see, it's labeled here as the bicuspid valve, and that's because it has two cusps or two leaflets versus three, like the tricuspid valve. One thing also you'll note here, and you can see it in this diagram very nicely, is that the left ventricular wall here is much thicker than that of the right ventricle wall. And that's because the right ventricle is only pumping blood to the lungs, and that's it. And also there's the pulmonary circulation is a low resistance system, low pressure system, versus the systemic circulation is a high pressure, higher resistance system. And it's just more surface area you got to pump blood to. So the wall of the left ventricle is much thicker to give it much more strength and enable it to pump more blood and generate more pressure to make sure it feeds the entire systemic circulation. And that concludes our discussion of the important structures of the heart, the chambers, the conduction system, kind of the overview of its function and physiology. In the next lecture, we're going to dive into the heart valves, their structure, their anatomy, and then the important clinical correlations with all the different valves.